knees and hips are your largest joints. They support your body's weight and must work in close coordination to provide the mobility most people take for granted. Troubleshooting Guide to Hip and Knee Pain. Tonight, on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc. Health information based on science, built on trust. I'm your Prairie Doc host, Dr. Andrew Ellsworth, and tonight we will be talking about hip and knee pain. Hip and knee pain are common ailments that can significantly impact daily activities and quality of life. Pain in these areas can be caused by a variety of factors such as overuse, injury, arthritis, or underlying medical conditions. If you are experiencing persistent joint pain that does not improve with rest, ice, or over-the-counter pain medication, it may be time to see a doctor. Hip and knee pain can be debilitating and interfere with daily activities. Remember that early intervention is essential in addressing lower limb pain to ensure long-term joint health and function. Tonight, we will focus on orthopedics and take viewer questions. Thank you for joining our program. We are joined in the studio by Dr. Anthony Fiegen from Orthopedic Institute in Sioux Falls and a clinical instructor in surgery at the USD School of Medicine, Dr. Jeffry Dessander from Avera Orthopedics, Brookings, and Dr. Jonathan Buchanan from Avera Orthopedics Sports Medicine in Sioux Falls, and a clinical assistant professor in internal medicine at the USD School of Medicine. Thank you so much for joining us here tonight. Dr. Fiegen, if you don't mind starting us out, tell us a little bit about yourself and your background.
Sure. Thanks for having me, Dr. Ellsworth. Good to see you again. I grew up in Madison, South Dakota, just down the road. And then I came to SDSU after high school, spent 4 great years here. It's great to be back on SDSU's campus, had a lot of fun here. From there, I went to USD Medical School, became interested in orthopedics and trained at the Mayo Clinic in Minnesota for my orthopedic surgery residency. And then I chose to get some additional training in sports medicine, and I went to Wake Forest University in North Carolina for that. And then just started practice about 6 weeks ago, so very happy to be back in Sioux Falls.
It's great having you back in the area. And just for some of our viewers, because some of them might be trying to put their finger on it, they might have heard you because what did you do here at SDSU?
I played some hoops.
Played some hoops. We'll leave it at that. Sounds good. Dr. Dessander, if you don't mind, tell us a bit about yourself.
Sure. I've been grew up in the Midwest, went to medical school in Chicago, and did my surgical training in Madison, Wisconsin. I've been doing general orthopedic surgery, so helping patients of all ages with a variety of orthopedic issues for over 20 years. I've been in Brookings for just over a year, and glad to be here, part of the community.
And we certainly appreciate you being here and serving us, because there's always so many joint issues that people have. It's nice to have you here.
Sure, thank you.
Absolutely. And Dr. Buchanan.
Yeah, so I am originally from Salt Lake City, Utah. I did my medical training at the University of Utah Medical School. Then I did an internal medicine residency at Maine Medical Center in Portland, Maine. And my fellowship in primary care sports medicine also in Portland, Maine. Then I switched Portlands and moved to Oregon, where my wife is from, and practiced there for 3 years. And then we decided we wanted a change of scenery, so we came to Sioux Falls. I've been here for about 7 years.
So something kept you here, huh?
Yes, something. Something. I've fallen in love with South Dakota. It's my first thought when I came to South Dakota was Sioux Falls. As I drove through the neighborhood, I'm like, I'm in the 1980s again. Kids are out playing, there's no fences, people come out and say, hey, dinner time, come on in. And on the coast, it's not like that. Kids are inside all the time, and gates are locked, and people don't talk to each other. It's nice to have those family values.
Awesome. So, and you had a nice perspective for our conversation today, because we have 2 orthopedic surgeons. You guys are using the hammers and the saws and fixing things, right? And some other things, but and what do you primarily do?
My practice is mostly focused on function. So people come in pain, and I quickly shift them to function. Why are you having pain? It's probably because you're having weakness in one part of your body that's caused overuse in another part of your body. And so I hone them in on how they can be their best self by getting stronger where they're weak. And I encourage a lot of diet and exercise, and most patients come to me because they don't want to be in the operating room. and they want to get their joint pain to go away without needing surgery. So there's a lot of injection options, a lot of rehab options that we can do, and that's been my niche.
Awesome. Well, before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about hip and knee pain. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. But it is not required to submit a question. The winner will be drawn and announced at the end of this program. So to start out, let's focus on the hip. Tony, if you don't mind telling us, why as we age do people have more hip problems?
Sure, for a lot of the reasons you alluded to a bit ago, there are certainly some conditions that predispose hips to arthritis. There's a condition called hip dysplasia where the socket doesn't form normally and it ends up in the hip just being relatively undercovered. And that can lead to some abnormal loading of the hip joint and subsequent early degeneration of the cartilage. There's also a condition called femoroacetabular impingement, which people in sports are talking a lot more about. And that's actually a condition where there's overcoverage of the socket and a bump on the femoral head. It decreases the sphericity of the femoral head, so as you can imagine, with certain motions, there's abnormal contact, and this is something that can also cause early onset arthritis. Of course, there's medical conditions, rheumatoid arthritis, inflammatory arthropathies, things like those. And in addition, post-traumatic arthritis, or after an injury, cartilage takes a hit and can subsequently lead to arthritis.
Sure. And so, John, after someone's been having hip pain, and if, before we're starting to think about surgery, what are some things you would recommend?
Well, I have to do an evaluation first. Usually I talk to them about their habits. My 2 favorite questions are, what do you do for work and what do you do for fun? So if their work is causing them to overuse a certain body part, like if they sit for a long time, my mantra is sitting is the new smoking. So sitting's not good for you. You sit on the most important muscles you've got. So if you can find a way to shift the way you work, then it can change. Hip pain is a lot of the times hip pain is because of weakness in your back. Weakness in your glutes, and you're sitting too long, or you're not moving appropriately, and then your hip starts wearing unevenly. People get what they wear on the inside or they wear on the top based on how strong their pelvis is. And if I can focus in on that and say, well, this is where you're weak, let's get you strong. And they almost always say, well, it hurts to do exercises, so that's where injections has a role.
Sure. And so what are we injecting when we're doing an injection, Jeff?
Well, for hip joint injections, there's quite a few things that can be used. Commonly are the cortisone type medicines, or the really strong anti-inflammatory medicines that help block the inflammatory pathways that causes pain of these arthritic joints. Work fairly quickly. They're pretty easy to administer. For most patients, the side effects are really small or minimal, with a big upside. So that's a good place to start for a lot of patients. Patients who are a little bit younger, maybe they don't have quite severe arthritis. There might be other things. There have been some advances in doing things called stem cell injections, platelet-rich plasma injections in some settings. Still need to be a lot of research still to be done on what the right combination of those new treatments might be, but there are some other options for the hip pain patients.
This caller from Alcester asks, is there any harm in postponing a total hip replacement? So let's say someone's been having issues and they've been thinking about replacement. What if we're not ready? Any harm in waiting?
I don't think so. We're trained in residency to perform surgery. I think it's unfair to patients the first time you meet them to offer surgery if they've not tried other things. There are many things that we have that are very simple that can get people back to activities pain-free. Maybe not pain-free, but to a level that they're still able to carry out activities that they enjoy or occupational tasks. I usually tell patients in clinic, when your bad days outnumber your good days, or you can't function on a daily basis doing things you enjoy because of the joint pain, and you've tried all the things that we have to offer you with staying out of the operating room, non-surgical measures, physical therapy, anti-inflammatory medication, even injections, then it might be time to consider joint replacement.
Sure. And along those same lines, this email asks, I just revisited figure skating after a hiatus, and I've been struggling with both my hips for the last year. I've had some gnarly falls and have been in PT per the referral recommendation of my PCP, but nothing is improving. In fact, the flare-ups are almost unbearable. Sharp pain, aching throughout the day, night, limping, trouble being mobile. Any advice for this person and their pain?
Well, when you go back to a sport after a hiatus, usually you think you can perform at the same level you did before the hiatus, and that's not generally true. So my advice would be to start as if you had never ice skated before. Start with the basics, start with some basic core strengthening, core training, and skate just back and forth across the ice before you do anything fancy. I don't know if this person's falling because they're trying to do a triple, whatever it's called, and they land hard. I don't know. But that could be what it is. So starting to, and the other thing too is as you age, you have less muscle mass in your body usually. So you need to build up the muscle to get stronger before you attempt things that you did when you were younger.
Yeah. So if someone's starting to consider a hip replacement, what are some things they may need to get lined up, Jeff?
Well, it depends on what they do for work. Because after hip replacement, at least immediately after, they won't be as mobile as they were, while their pain often is remarkably reduced right after the operation. There will be some time needed to spend getting rehabilitated, getting stronger, getting their stamina back before they can get back to their regular activities again. So they need to plan on at least, I tell patients, at least 3 to 6 months of time to feel like they're back to normal again. Now, having said that, they'll be walking from the day after surgery. They'll have a lot less pain the day after surgery, but it will take some time for them to get comfortable and feel like they're walking like they were before surgery and have the strength and stamina that they did before the operation.
What are some immediate goals after surgery that you have for patients?
Even before the surgery, having a good plan for after surgery. Many joint replacements nowadays with advances in anesthesia, periarticular blocks, et cetera, many patients are able to go home on the same day of surgery as an outpatient, which has really kind of revolutionized arthroplasty practice. As far as planning going home, I usually ask patients to make sure that they'll be able to kind of navigate on a single floor. Navigating stairs can be difficult the first couple days after surgery. And then just developing a plan for pain control after surgery is important too.
Absolutely. And I might add as a primary care doc how important it is to have that plan to help prevent a clot, a deep vein thrombosis, and whether that's going to be medication and staying active and moving around and not just sitting around on the couch or anything like that. This person says, I have a question regarding hip flexor pain in the groin area. I usually get pain when I wake up or start running or walking, and then within 20 minutes, pain goes away. What could this hip pain be when walking and running be? What would you say to that?
People always say hip flexor, and it's hard to say if that's really what it is. So my general rule of thumb is if it hurts when you're doing stuff, it's more of a tendonitis. If it hurts more when you're done doing stuff or when you've been sitting for a long time, it's more arthritis. And if it hurts no matter what you do, it might be a neuritis. And so there's a nerve there that can cause pain. There's the psoas that can cause pain. The rectus can cause pain. The hip joint proper is just behind your hip flexors, so it could be a joint issue. Usually if it hurts for the first little bit when you're running and it starts to feel better as you go, it's probably more impingement or arthritis, depending on the age of the patient, health of their cartilage.
Absolutely. Yeah, it can be so tricky to know when someone comes in complaining of hip pain, if that's really what's going on. Dr. Dessander, what are some of the things you're looking for that might clue you in that this might not be your hip joint that's the issue?
Well, talking with the patient, getting a timeline as far as their pain has been progressing, and then examining the patient. Are they developing stiffness of the hip joint? Are they having weakness of the muscles surrounding the hip joint? We also routinely will get an X-ray of the joint to help us determine if there's a bone or joint issue causing the pain, such as arthritis or sometimes a stress fracture of the bone can be an issue that's not always thought of. So we take a comprehensive approach to try to localize their pain and the cause of their pain.
Absolutely. It's an amazing number of times I'm sure you guys have seen where someone is focused on their hip and maybe it's their back. That's the issue.
Yeah, the location of the pain will often give you some clues to, pain if they point to their groin, usually it's the hip joint or the hip flexors. If they're pointing to the part they sit on, sometimes you're thinking maybe it's a lumbar or lower back cause. One thing that I think we probably have seen or heard stories is a patient who complains of knee pain. Repeatedly comes to see them, knee pain, or they see their primary doctor. But the knee checks out fine, there's no weakness, no instability, no arthritis, but the knee still hurts. Well, sometimes hip pain or problems in the hip joint can refer down the thigh to the knee. So especially in pediatric patients, we want to make sure that they are having their hip checked out too, because there's some serious hip problems that can refer or radiate pain down towards the knee that sometimes are not top on their list of diagnoses. So.
And I know sometimes a labral tear can be tricky to figure out that that's the issue. What is that, and how can you determine that?
Yeah, a labrum tear, we talked about the ball and socket of the hip joint. The labrum is basically a fibrocartilagous ring that deepens the socket, if you will, and adds a little bit of additional stability. You can have a labral tear. We commonly treat them with hip arthroscopy nowadays in the younger population. There have been good studies that show that, for example, if there's 50 people in a waiting room in a clinic, once we get over the age of 40, 50, over half of those people will have a labral tear that would be able to be detected on an MRI. They're just not always symptomatic. So while patients often do come with a labral tear, it's really important to kind of get a thorough workup of imaging, et cetera, get a timeline, and try and get down to the root cause of their symptoms. A lot of times the labrum degenerates as a joint degenerates. So most of our arthritic hips that we end up replacing at the time of surgery, the labrum is torn. And so while it can occur in isolation, it can also occur as a result of arthritis and just overall degeneration of our joints.
Sure. Very good. Well, in the U.S. alone, surgeons perform more than 600,000 knee replacements and about 330,000 hip replacements each year for patients usually between the ages of 60 to 80 years old. Prairie Doc spoke to a Brookings man about his recent hip replacement experience.
Towards the end of 2002 was when Don Norton felt as his hip was getting worse day by day. He then spoke to his general practitioner and decided to get connected with an orthopedic surgeon about his options.
It wasn't just achy sore. I'd take maybe 10 steps and get a real sharp pain. And I thought, well, I just can't go on like this.
He thought the surgery would take place in 3 to 5 years, but to his surprise, they told him in about a year he would need the hip replacement procedure.
There is important prep before the surgery. You're given exercises to do. And if anybody out there is going to have a hip replaced, let me recommend doing the exercises.
The exercises are to strengthen the muscles that will be impacted both before and after the hip replacement. Not only are the exercises done prior to the surgery, but also after.
The exercises before the surgery and the physical therapy and exercises after the surgery are so important. It's what's going to help with a smooth recovery.
The day of the surgery, they have you walking up and down the hall after the procedure, but want patients to use a walker for stability about 10 days after. 7 to 8 weeks after his hip replacement, he felt comfortable doing just about anything like he did normally.
I think the doctor said to me on the follow-up checkup, it'll probably be a year before you forget that you had a hip replacement. And I'm not even sure it was that long.
Well, I'm glad he had a great outcome. You know, are hip replacements typically a one-time thing, or sometimes do they have to be redone, Dr. Dessander?
Well, we hope we're getting closer to them being a one-time situation. Traditionally, we had been seeing patients in their late 60s and 70s and beyond with arthritis that would be helped by hip replacement surgery. Unfortunately, we're seeing younger and younger patients with really advanced arthritis damage to their hips. Lots of factors for that, maybe old sports injuries, hard-working people. Unfortunately, even excessive body weight has been a really common cause as well. So we're seeing younger and younger patients. Those patients had presented a challenge because the durability of the parts we had available, unfortunately, would not typically last them their entire lifetime because they typically place more stress, more demand, more wear and tear on those artificial parts. Now, there's been quite a few advances in the material durability that we have to use for these younger patients. So we think that we might be closer to a hip replacement being a one-time procedure that they have to go through.
Yeah, very good. Well, let's move to knees for a little while. Dr. Fiegen, where do you usually begin when a patient comes to you with knee pain?
Sure. I typically begin first by asking if there was an injury that had occurred, and if not, the onset of their symptoms. The timing is important, when it does, when it doesn't bother them, certain activities that are aggravating. Certainly, we can kind of key in and start a differential diagnosis or what we think is going on based on the presence or absence of mechanical symptoms, swelling, how they respond to rigorous type activities, and then simply asking patients to point where they feel like it hurts the worst. The knee is a little bit easier in the clinic to try and develop a differential diagnosis than in the hip. You can lay your hands on the knee pretty reliably. The hip is much deeper. So just getting a comprehensive history, usually some x-rays is a good place to start.
Good. And Dr. Buchanan, from there, where do you go with knee pain?
Well, biomechanical evaluation. I know I sound like a broken record here. My favorite go-to is a single leg squat. If I had them stand on one leg and they can't even balance, we know we got some issues with biomechanics. The knee as a simple hinge joint is usually the victim of weak hips and core. So if we can get their glutes stronger and get their knees over their toes, if they're quad dominant, their knees are way over their toes as they squat and bend, pick stuff up, their patellofemoral joint is going to wear out super fast. So if their knee's dropping in, the medial compartment tends to wear out a little bit faster. So biomechanics, you say you're clearly weak. And I love talking to athletes that have knee pain, especially like gymnasts. I'm like, look, you're weak here. Because they're like, no, I'm not. I can, where am I weak? I mean, they can try to, it's more competitive, right? They want to get stronger so they can prove to me that they're strong. I'm getting to the point in my age where I can't really demonstrate those things anymore because I myself am getting a little weak, but that's my starting point. I go with the weak, where they're biomechanically a little bit more weak, and I focus in on that.
Very good. So in the situation where they've tried some non-surgical treatments, where do you go once they're reaching your office, Jeff?
Well, like we have talked about before, even though we're trained to operate on people, the vast majority of people that we see in the clinic, we can treat without surgery. But if we've gone through the treatments, and we often work in conjunction with physicians like John and physical therapists to help, people be more active as possible before having to broach that surgical topic. But if they've tried all those things, therapy, injections, medications, and they have severe arthritis that we can demonstrate on an x-ray, they become candidates for joint replacement surgery. Similar to what we do with hip patients is we have to have a discussion about what to expect after knee replacement surgery. In my experience, the knee replacement patients don't send me thank you cards right away like my hip patients do. Mm-hmm. It takes them some time to realize that they made the right decision as far as I'm going to feel better, I'm going to have a lot less pain. It takes knee patients longer because the initial therapy and rehab needed for knee replacement is much more painful because they're having to stretch a muscle that we had to do some cutting into to get to their knee joint to do the operation. So the initial phase of their recovery is not as smooth and pain-free as they might expect. So educating the patient beforehand to be prepared for that is important.
Absolutely. And Tony, if you don't mind, do you have a knee with you here?
Yeah.
Why don't we get that out? And yeah, absolutely. I often tell patients when they're seeing me for their pre-op, in that first month or so, you're probably going to regret that you did this. Mm-hmm. And then after a while, in a few months in, you're being glad you did it, and then 6 months later, they wish they had done it.
I go from being their friend to
sooner.
Not their friend to their friend again in a few months.
What are you doing during a replacement here with this knee?
Sure. So we have a knee model here. This would be a right knee. To do a knee replacement, typically it's an incision. We've tried ways to do it minimally invasive. It's still not quite there. And so you end up with an incision over the front of the knee. This is what we call the extensor mechanism, which is simply put your quadriceps to your patellar tendon. And usually what we do is make what's called an arthrotomy. The joint is surrounded by a balloon, and it's the capsule that we have to cut into. That's called the arthrotomy. And then essentially just move the extensor mechanism to the side, a little bit of knee flexion to expose the joint. It's fun talking to patients. I think knee replacement's maybe a little less morbid than people perceive. It's not a full replacement per se, it's more of a resurfacing operation where just the ends of the bone are covered with cobalt chrome implants in most cases, with a piece of articular plastic between the two metal components, one on the thigh bone, one on the shin bone.
Yeah, a lot of patients are under the impression that we're removing this whole area of their leg and putting a big hunk of metal in there. It's really much more bone preserving procedure, just taking the ends off, like Tony said, and so we preserve as much bone as we can to put those implants into.
How has the advent of robot-assisted technology helped?
I think it's helped us be more consistent and reproducible as far as our results go, more precise in sizing and positioning the parts for each patient so we can give each patient a custom knee that's very stable and works really well, which is, of course, the goal of every surgery, a well-functioning joint that's stable that will last a long time. And the robot, I think, has helped me be more consistent in balancing the knee, making sure it's stable in every direction, which has translated into increased patients' satisfaction and them feeling better sooner, I think.
Yeah. And we will actually, our next roll-in, we're going to be talking a little bit more about the robot and everything. Dr. Buchanan, so when someone sees you, and let's say they've already had a knee replacement and they're still having issues, can you help them yet?
Yeah. First of all, it rarely happens. So most patients that get knee replacement are happy. My first question is, did you do the rehab? Rehab. Were you able to get your knee fully flexed? Were you able to get it fully straightened? If they didn't, they kind of dug themselves into a pit, and they're probably going to be suffering because of that. But outside of that, there's a lot of things outside the joint that can cause pain. I've had a few people that have had a lot of quadricep pain because the incision across the top of the knee either entrapped the anterior femorocutaneous nerve or caused some quad tendinosis. And so I do some tendon-related procedures. I do a TENJET procedure. I do PRP for the quad tendon. There's these, so the knee, even though it's just a bend and straighten joint, you've got some stabilizing tendons on the outside. On the inside is your pes anserinus, which is where a bunch of tendons and part of one of the ligaments attach. On the outside, you have your IT band. Those are kind of the side-to-side wobblers. Sometimes they can be a little bit off, either from the stretch from the surgery or just because they were pretty weak to begin with. So treating those tendons individually can help, either with PRP or TENJET procedure.
Excellent.
Yeah, you make a good distinction. I think the knee is a more complex joint than people give it credit for. They think of it as just bending and straightening, but there's a lot of other motions that occur as we bend and straighten our knee that make the replacements a little more challenging because we're trying to balance all those different motions to help make the knee as stable as we can. Do you agree?
Absolutely.
Yeah.
To Dr. Dessander's point, one of my mentors in residency said total knee replacement is a soft tissue operation. And that's to tail on the robot. That's why I really enjoy I like to use the robot, is because it really lets you position components according to the soft tissue tension. Traditionally, we used to cut, the tibia at 90 degrees, even if you were a little bow-legged or valgus or knock-kneed. And that would, if you're bow-legged, you're tight on the inside of your knee. So if you cut it at 90 degrees and bring it out then straight, it leads to soft tissue balance issues on the inside and the outside. And I think now with the robot, you're able to leave the alignment of the leg in a little bit more of its native position while respecting the soft tissues. And I think that's one of the major benefits of using the robot to help with the operation.
Well, let's talk about it. Robotic assisted surgery helps surgeons perform precise and minimally invasive procedures. At Brookings Health System, it is a common procedure becoming more relevant. Dr. Jeffry Dessander explains the Mako robotic arm and how it operates.
Well, right now the Mako is used for knee replacement and hip replacement surgeries. It may soon be used on shoulder replacement surgeries as well, but right now it's approved for use for hip replacement and knee replacement surgeries.
Before the surgery, patients have a 3D computed tomography scan, also known as a CT scan, which is a special X-ray of their knee or hip. That scan helps the robot tailor and start the surgery process.
Surgery can take anywhere from 60 minutes to 2 hours, or depending on the complexity of the procedure and the patient's knee and their anatomy. Sometimes patients come in with a very damaged knee that's very crooked, let's say, and it takes a little bit more work to get things put it in properly and straight, so that may take a little bit longer than a more straightforward knee.
Dr. Dessander said patients are usually excited when it comes to having the Mako surgery done.
When they find out that we have that technology available here in Brookings, they're really excited that they can stay local for the most advanced surgical techniques around.
The surgery is close to traditional surgery without the Mako robot until it is time to make bone cuts. The robot aids with the bone cuts due to having the 3D CT information of the patient in its memory.
The robot knows where the bones are. It's able to control the robotic arm so we can precisely cut the bone in a much more exacting fashion than before, where we were using cutting guides that might shift a little bit as we're putting them on or moving them as we're sawing, whereas the robot stays in a perfect position every time we make a cut.
The Mako robot-assisted surgery can make for an easier and faster recovery process.
That's what's been so exciting, is we're able to do that very predictably, more consistently, which is what we're trying to do, maximize patient satisfaction, and the robot allows us to be more precise in accomplishing that.
Well, that's great, the advances in technology and how that's helping patients and minimally invasive and faster recoveries too, I'm sure. Have you seen that in your career?
Yeah, we were just talking about how knee patients take a bit longer to realize the pain relief benefits. I think that since I've been using the robot, patients are getting there quicker because their knees are very well balanced right from this, which helps make their rehab easier, helps, I think, them regain their strength easier and quicker, and just has helped their whole recovery, I think, speed up a little bit.
Well, we've laid a good foundation about these topics, and now we're going to get into all these different questions that people sent in. So this person from Mitchell asked, should a tingling sensation after a total knee replacement be a cause for concern? Tony?
It certainly can. Surgery is a big deal to the soft tissue envelope of the knee. With that, inflammation in the soft tissues can cause neuritis or a temporary inflammation, even around a nerve, cause nerve symptoms. In the first several weeks after surgery, it's not uncommon to hear this from patients. Usually try and just encourage them that your soft tissues take time to heal. And in most cases with subsidence or improvement in the swelling, they seem to self-resolve, but nerves get irritable very easily and they can take time to heal. If it gets to be too long, it might be something worth asking about with your surgeon.
But if it's initially, maybe give it time and it might calm down.
Yeah, and nowadays our anesthesia team is so great about doing peripheral nerve blocks. And sometimes I kind of wonder if maybe the nerve blocks hang out a little bit longer than anticipated, just to irritate the nerves a little bit. So I don't think that that's uncommon.
Sure. John, this person from Arlington asks, what are stem cell injections and can it be used on any joint?
That's like kind of a loaded question. There's stem cells. How much time do we have to talk about them? No, just
That's
kidding.
a whole other show.
I know, exactly.
We can preview it now, though.
I know. Stem cells are essentially cells in your body that haven't decided what they want to be when they grow up. So when you're a baby developing, some cells differentiate to different body parts. And there's always a few left in reserve because you never know throughout your life what you're going to need. If you have a heart attack, thank goodness you have stem cells to become heart cells. If you have a stroke, so forth, for the brain, fractures, etc. And they live throughout the body, but most injuries to the joints are degenerative. There's not a really big injury all at once to them. And so there's really no bleeding or no trauma to activate those stem cells. So there's two different ways. Stem cells can be activated using PRP, platelet-rich plasma. It's a blood product that you inject into any joint. I've done a lot of the joints in the body, from the spine to the fingers, the toes, and all the major joints. And that wakes up stem cells that already live in the joint. And they can transform to whatever they touch. Now that's kind of a tricky thing, because if they touch fibrocartilage, they'll turn into fibrocartilage, which is softer and wears out quicker. If they can somehow only touch hyaline cartilage, which is pretty rare, they can turn into actual hard hyaline cartilage. In my experience, if patients have really bad degenerative arthritis, they've got, more on the moderate to severe, they're older maybe, and they just can't have surgery, then I actually harvest stem cells from places where they're the most plentiful. If you think about what happens throughout your life, most of your injury hits the skin, right? You scrape your knee, you cut yourself, whatever. So most of the healthy, viable stem cells live in the adipose or the fat layer right under your skin. So a small incision, numb up the skin, remove that fat, and inject it into the joint. There's also, with bone damage from advanced arthritis, you want bone marrow stem cells. So I can take bone marrow from the center of the pelvis and put that into the joint. So depending on how the problem is, how bad the problem is, and the patient and so forth, stem cells can be used throughout the body.
That's great. This person says, I was diagnosed with a groin pull several months ago and stayed away from sports until the pain went away. Now that I have begun playing again, the pain has returned. Do you think it could be my hip? What do you think about this question here about a groin pull and what the cause might be?
Sure. It certainly could. I'd like to just get a little bit more description if we were in clinic, of course. But certainly after an injury such as a muscle strain, these are things that, if you watch football on Sunday, you hear about a muscle strain. These take time and more time. Yeah. Physical therapy, ice, all the simple things that we can throw at it, and more time.
Yeah, whatever joint, or tendinitis, and I think of the twins and losing people half the year because of plantar fasciitis, and it can be so frustrating.
Definitely frustrating injuries.
Frustrating. As a fantasy baseball manager, I'm sure it's frustrating.
There you go. This person says, I was diagnosed with degenerative disorder disease, and did all epidural shots, physical therapy, chiropractor, 400 milligram Celebrex every day, but still aches. Sounds a little bit more like a back question, I guess, with the epidural injection there. But Dr. Dessander, what would you recommend to someone that they've been trying shots, they've been doing physical therapy, Celebrex, and they're still having issues?
Well, they are exhausting all the conservative treatments that we've talked about that we all employ when we're trying to treat somebody's painful joint. It may be time to consider some advanced imaging studies, such as a CT scan or an MRI of the spine. They may be dealing with a more significant degenerative condition called stenosis that is the overgrowth of bone spurs around the joints between the vertebra that could be squeezing or compressing the nerves that are causing pain. There's a lot of other potential serious conditions that may be at the root cause here, so there may be a need for some more advanced imaging studies to help give us some more insight.
But no point in giving up. There might be hope. Yeah.
There we go.
2-second answer, how can I avoid hip pain when running? Well, not 2-second answer, but maybe one.
How can you avoid hip pain when running?
Avoid hip pain with running.
Good question.
Geez. I always go to footwear. If you're wearing good, if you're strengthening your feet. There's another soapbox that I've got. I'm more of a minimalist barefoot type runner, which isn't a topic for today. But oftentimes you get hip pain when you're running because you're hitting your heel too hard. You have that big, thick sole and your heel striking too much, and it causes too much jarring through the body.
Yeah.
How often do you see knee pain in runners that you attribute to weakness of the gluteal muscles and the hip muscles? Is that a pretty common scenario?
I call it runner's butt.
Yeah.
Yes.
Yeah.
Yeah. Every runner's got glute weakness, and if long distance are the worst.
Mhm.
Sprinters are usually better.
Yeah.
But yeah, it's glutes, but it's also arches.
Yeah.
If you're falling, your arches are falling, your knees rotate in, your tibia rotates in, and it starts wearing the inside. IT band syndrome is from weak arches. So.
And I should add the hip pain that's right on the edge, right on the side, greater trochanteric bursitis, is so common too, and it's not even in the joint, it's in the bursa sac, and one of the best treatments for that is glute strengthening.
Exactly.
So yeah, it can be the answer for so many things.
If everyone in the world had strong glutes, I'd be out of a job.
So they should just do squats, right?
Yes. Well, rotational squats, side squats. Most of our sports, and I'm going to go back more anthropologically, but as we developed as human beings, we did not have smooth surfaces to run on.
Sure.
We leaped over boulders, we climbed trees to try to escape the saber-toothed tiger, find food, whatever. And so we used all of our muscles equally. Introduce streets and sidewalks. Everything is so linear, there's no side to side.
Yeah.
And it's the side to side glutes that get weak.
Sure.
And so I say, all my runners, you got to either cross train or work on your glutes. So play tennis, play racquetball, play soccer, something that involves sudden changes of motion, and you start using those glutes that you were supposed to be using.
But that's what makes my knees hurt because of my high school football injury.
I know. Take it slow. And those patients, you do work the glutes on the physical therapy, the exercise, Pilates. I'm a big fan of Pilates.
Yeah. After a fall in March this year, breaking my right tibial plateau, I'm experiencing stiffness in the knee joint. No surgery was needed for the break, just a soft brace from my ankle to my thigh. What can I do to help my knee? Well, first off, what's a right tibial plateau fracture?
Tibial plateau fracture is a fracture of the articular surface of the shin bone or the tibia. So where the shin bone's contribution to the knee joint at the top. It's a very tough injury. Most of them, maybe not most of them, but many of them do require surgery. Puts you at this type of injury specifically is one that puts you at risk for post-traumatic arthritis, like we talked about earlier. It can alter God made us so that our knees are nice and congruent, and with a tibial plateau fracture, you can have step-offs, and it leads to abnormal joint mechanics, point loading, etc. And arthritis is an inflammatory condition, makes the knee hurt. Moving the knee when it's inflamed hurts, and so it just kind of sets off a cascade. And so my recommendation is just limiting the inflammation. We can do that pretty easily with over-the-counter medication, and getting back to physical therapy. I like to use the words "motion is lotion." I'm not sure where I heard it, but it's very true.
Very true.
That was something Dr. Holm repeated often. He was the founder of this show, so yeah.
Awesome.
Yeah. I'm not saying it was from him, but I don't know.
Right. I always talk about diet with my patients too. Certain foods are more inflammatory, certain foods are anti-inflammatory. So before, you got the anti-inflammatory medications, they can help, and they help right away, but they're not without their side effects.
Sure.
So I'm always a big proponent for eating clean. So the more whole foods you can be, the less processed food you can be, the less inflammation your body sees. Our body spends so much inflammation just trying to process all the artificial garbage that we eat every day long. If you can cut that out, then your inflammation goes away.
And that's going to help with all the other
Everything
problems
else.
in the body too.
Absolutely.
Have you had luck with any supplements in particular? I heard turmeric and fish oil.
Yeah.
Which ones do you like to recommend to your patients?
Turmeric, I recommend almost everybody. Some people don't like the way it tastes, My favorite is tart cherry juice.
Okay.
You can get it in like some natural food stores, but I go down to Trader Joe's in Omaha and get a bottle of tart cherry juice and maybe an inch every night before I go to bed, and it's amazing.
What about apple cider vinegar?
It's another one too. I'm not a big fan of vinegar. Upsets my stomach, but it'll work too.
Yeah. Sure. Jeff, this person from Arlington says, when patient wakes up in the morning, the first 25 steps are very painful in the right side of the hip. The rest of the day, patient reports no pain and wonders what could be causing the initial morning pain.
It's a lot of things are more painful in the morning. because when we're sleeping, we're usually not moving and we're in one position and not stretching and moving our muscles and joints. So if it's pain on the very outside of the hip, it may be something that we talked about, like a bursitis or tendonitis, that takes some time to loosen up with some lotion-producing motion.
That's right.
But a lot of conditions such as arthritis or tendon and muscle issues can be more stiff and sore in the morning. Also in the foot, plantar fasciitis is very stiff and sore in the morning until people take a few steps and get things stretched out. So depending on the location of the pain, it could be a muscle issue.
Here's a basketball player. I recently hurt my knee playing basketball. Whatever the cause may be, I instantly felt pain in my knee. Specifically, since then and until now, I'm in pain when I try running or jumping. There was and still is slight pain when I bend my knee too much. That has been getting better. Should I just wait and see it gets better?
I would say if it's persistent, if you're not able to do things you enjoy, similar to arthritis, I think it's time to get it looked at. A good knee physical examination, you can figure out if something's worrisome or not in most cases. Worrisome things that I tell patients in my sports practice are if you're developing an effusion with activities. That means the joint capsule in your knee is filling up. The structures that we worry about in the knee when they become injured, ACL, PCL, they're very well vascularized, and if they're injured, they bleed, and that causes that effusion that many athletes notice. If you're not really noticing swelling, which often manifests as stiffness, difficulty with motion, a lot of these things are exterior. You know, in jumpers, I often think of patellar tendonitis, quadriceps tendonitis. Patellar tendonitis being coined conveniently jumper's knee oftentimes. Those things respond very, very well to some physical therapy, some topical anti-inflammatories, which is just a gel that you rub on the area that's sore. But if it's bothering to the point where you're not able to do things you like to do, it might be time to get it looked at.
That's a good general rule for any of these joints. Yeah, absolutely.
Common sense is a good thing to use.
Right. This person from Beersford experiences no pain or discomfort sitting or sleeping, but experiencing pain when walking. What could be causing the pain present only when walking? And actually, I don't know what joint they're complaining about, but once again, if it's bothering you when you're moving and walking, it's probably something to get straightened out. This person has bursitis in their hip. They've been doing PT for 10 weeks with no improvement. Hurts sitting and sleeping, no problem being active, and walking. What do you start to think about then? And now here's the opposite of what we were just talking about.
Yeah, I'm not, bursitis exists because the bursa exists over the greater trochanter, but it's also the epicenter of all the muscles around the hip. I call it the rotator cuff of the hip joint because you have all these muscles that are stabilizing it. My experience, if you treat the tendon, you treat the bursa as well, and so it gets better. So people are like, yeah, it's a bursitis, but in actuality, it's most likely a tendonitis. Pain with activity is usually more tendonitis. Pain after activity is usually more arthritis. If you have a bursitis this long, it's not getting better with physical therapy, you might want to get a better look at it. I usually plop an ultrasound on it because then it tells me if you've got some tendinosis, which is tendonitis is acute, tendinosis is more chronic. And if you're really starting to dissolve your tendon and starting to really scar in a bit, then it's better to take a look at it.
And sometimes with bursitis, I find an injection and therapy is helpful.
Yeah.
You know, why would an injection help? Jeff?
Well, if it is truly an inflammatory issue, then it seems with the bursitis and also with rotator cuff issues, that the oral anti-inflammatories don't seem to be as effective for whatever in my experience. People come, especially with chronic shoulder pain from a rotator cuff issue, not necessarily a tear, but just inflammation. It does not seem to respond to the oral anti-inflammatories, and those are instances where I think injections are more helpful in my practice. So some of these conditions I find from talking to people, it just doesn't respond to the Advil and the Aleve that we assume works for everything. You know?
We might just play Stump the Doctor right now because I've never heard of this. I'm going to see if you guys have heard of. Is it possible my Gilmore's groin might really be a hip impingement? Have you heard of Gilmore's groin?
Gilmore's groin. Too many things are named after doctors.
Right.
Or just named after random people. So
Yeah,
I don't know
more
what
to
to
the
kill it.
doctor. I don't know, it could be.
Yeah.
It could be. Yeah.
Sorry, I hadn't heard of that
bartender,
either. We'll have to get look that one up or do an exam, and then we could probably
Right.
Sure.
help them out. One more question about, well, we've talked about non-surgical treatments for hip pain, unless there was something additional you guys would add to that. Why my hip arthritis still aches after 2 epidural shots and Celebrex every day. Doctor said no surgery. What's the solution? So what do you do those difficult situations where they're not a surgical candidate for whatever reason, but they've got advanced arthritis?
Well, in the knee arthritis patients, there are some nerve block techniques that have become available where they actually freeze the nerves that we think transmit pain impulses from the knee joint. Those can be helpful to relieve pain in patients who are, for health reasons, not able to have an operation as extensive as knee replacement surgery.
Yeah. Would you add anything else?
Yeah, I do those frequently. The nerve, I use the Avera device. There's also the Coolleaf device that does that. You can do radiofrequency ablation for nerves. That's a little more destructive of the nerve, and it can cause neuropathic type pain. I always go to the stem cells too, even if it's like a Hail Mary. Even with really bad bone-to-bone deforming arthritis, I can usually get them by for, maybe 10, 12 months. And they come in every year for another PRP injection, and that does really well for them.
I think the bottom line is don't give up. You know, if you feel like you're running out of options, you can get another opinion. I'm sure your doctor would be happy to send you to someone else to get another opinion. And so I got to go to our winner now. Our winner is Kale. A book will be sent to you shortly. We'll be back after this.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
A big thank you to our guests, Dr. Fiegen, Dr. Dessander, and Dr. Buchanan, for volunteering their time to help us learn more about hip and knee pain. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB's Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Diabetes affects people of all ages. Most forms of diabetes are chronic and all forms are manageable. Diabetes, prevention, diagnosis, and treatment measures. Next time on Call with the Prairie Doc.
My name is Dr. Tom Dean, and I serve on the Healing Words Foundation Board, the nonprofit organization that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,